Good evening, everyone. Thank you for joining us today in this important webinar, New Hope for Treating Kidney Lupus or Lupus Nephritis, presented by Dr. Janet Pope. In this webinar, Dr. Pope will explore how kidney lupus presents itself, delve into the complex clinical features, discuss the latest advances in the treatment options with lupus nephritis. The objectives of this webinar are to learn how the kidney lupus presents and to be aware of newer treatments and hope for people living with lupus nephritis. But before we begin, let me give you a brief introduction to Dr. Janet. So, Dr. Janet Pope is a professor of medicine in the Division of Rheumatology at the University of Western Ontario, Schulich School of Medicine, London, Ontario. She is the division head in rheumatology at St. Joseph Health Centre in London. She obtained her master and fellowship in internal medicine in Western Ontario University, and then she did a fellowship in rheumatology and master in public health at Boston University. Then she completed the Canadian Arthritis Society Research Fellowship in Scleroderma. Her research includes epidemiologic studies in scleroderma, SLE, and RA, including outcome measurements, clinical trials, and disease manifestations. She has published over 455 peer-reviewed articles, 15 chapters, 500 articles, and several Cochrane meta-analysis reviews. The H index of Dr. Pope is 49 with more than 11,000 citations. She was the lead in American College of Rheumatology and the European League Against Rheumatism classification criteria for systematic sclerosis, mentoring students and training numbers more than 100 for research projects. Dr. Pope was awarded with the Lupus Hope Award. She received the Distinguished Investigator Award from the Canadian Rheumatology Association. She got the award for Rheumatologist of the Year from Ontario Rheumatology Association, also from the Department of Medicine Research Achievement Award, and she got the Dean Award for Excellence in Research. Uh, Before we start, I just want to let everybody know that for any question that you may have, you can post it on the chat, and once the Dr. Ash will finish her presentation, I'm going to read the question, and you will have the chance to get the answer from Dr. Ash. And now, without any further delay, I'm pleased to hand it over to Dr. Ash Janet. Thank you so much, Dr. Ash, and please, it's your turn.
Okay, great. Thank you. And thank you for people for attending on a busy weeknight, and probably good for everyone to mute for now because I think there is some background noise and that makes it more difficult, I think, for people to hear. And I certainly welcome questions. So as you heard at the top, there's if you kind of scroll across the top of your screen, if you find the chat, you can put a question in there and we'll get to it at the end. So what I want you to know is there is hope for people suffering with lupus kidney involvement. We call that lupus nephritis or glomerular nephritis. And I don't want you to think about, oh, I need to know all that I'm going to talk about. This is an overview, and it just shows a lot of research is going on. So I consult for a lot of different companies and do lots of speaking. So these are my disclosures. So we'll talk about, you heard the objectives, really understanding who gets kidney nephritis, kidney lupus, and what we do about it. And I think some hope on new and other treatments. So first of all, there are approved drugs overall for lupus. Not all these drugs are approved yet. Some are in phase 3 trials, which if they're positive should lead to an approval. Some are already approved, and not all these drugs are approved in kidney lupus. This is for active lupus overall. And you can see there are a whole bunch of names that are hard to pronounce, but they're affecting the immune system in many different ways. Some drugs are affecting the immune system in 2 or 3 pathways, other ones one of them. But any of these drugs, if they get to market, might help a person with active lupus. So there are thoughts in lupus, and this is why we need new treatments and why there are some new treatments that have been approved. Prednisone, so steroids, Solu-Medrol, cortisone, prednisone are bad. They help active lupus patients, but they can cause damage. So active lupus can give damage to organs, but prednisone, steroids also can give damage to organs, even though they can suppress inflammation. Other thoughts are we're trying to get people with lupus into low disease activity and then remission quite quickly. We want to treat to a target, getting most patients where possible to a low disease activity or remission. So we're trying to keep cycling on therapies and trying to keep the prednisone low or not at all where possible. We are learning about new definitions of remission. Can you have remission if you're on prednisone or only if you're on low dose or none at all? High disease activity, definitions for inflammatory arthritis, changing the outcome measurements, and some studies on withdrawing treatment or tapering treatment when people are in long-standing remission. So a lot's going on. Let's talk though about kidney lupus. So lupus nephritis, I'm talking about very active kidney disease. So this is a very bad slide because they're looking at patients from January 2005 to August 2021. So over a 15-year, 16-year time frame in multiple databases in the United States. So it's like looking at their charts, their EMR, their data. 25,000 lupus patients, 15% had lupus nephritis. So why is this a bad slide? Look at the two red things, end-stage kidney disease in 2 years. 1 in 4 of these patients will have end-stage kidney disease. By 5 years, 1 in 3. That is unacceptable for our patients to be in kidney failure. Now, I think that most of these patients would be the most severe lupus nephritis because it's saying 15% of this lupus population. It's probably in the real world more like 30%. So that number could be diluted. But even if you dilute the bottom by, I cut the percent in half. 1 in 6 for 5 years having end-stage kidney disease is unacceptable. That's kidney failure. So there are guidelines, the three main guidelines that have come out recently. The Kidney International, so KDIGO, the new American College of Rheumatology guidelines for kidneys, lupus nephritis, and the European League Against Rheumatism, or EULAR management for lupus, including kidney lupus. So these are mostly, fortunately, the same, and the spirit of them is highly similar. They're not identical, but they're highly similar. So if we look at US and Canadian epidemiology, so about 1/3 of people who are adults living with lupus will get lupus nephritis, kidney involvement of their lupus. It's higher in kids, by the way. And over 10 years, up to half of people with lupus will have lupus nephritis. Not all of it severe, but that's a lot of people that we have to follow and worry about. It's higher in some ethnicities, a bit lower in whites, higher in African Americans, higher in the Canada on our native peoples, and higher in Asians, particularly Southeast Asia, like Taiwan, Korea, Philippines, things like that, Korea, Japan. So there is a classification for kidney nephritis, and we're only thinking about class 4 and 5. That's class 4, diffuse proliferative nephritis. Sounds bad because it is. It's diffuse a lot of areas. Class 5, membranous, so a different kind that happens in lupus. And class 6, by the way, is damage. So class 4 and 5 can lead to class 6 damage. The other ones are milder. So when we talk about lupus nephritis treatment, we're talking about class 4 or 5. So how does this all happen? So people have a genetic immune predisposition. They get a trigger, many triggers, viruses, stress on the body, who knows? Lots of different triggers, and they start making antibodies against themselves. So that's kind of what's happening. So the lupus nephritis, it's an autoimmune, just like lupus is autoimmune. This is part of systemic lupus. Certain cells in the immune system that make antibodies are activated, such as the B cells. You get antibodies against your own nuclear proteins. We're not supposed to see our nucleus. When cells die, the nucleus basically should be cleared away on normal programmed cell death, and it's prolonged in lupus patients, so you can get autoantibodies. You make complexes, antigens that you're making antibodies against the nuclear debris, so antibodies in the nucleus, and you recruit cells to say, hey, there's inflammation, let's try to get rid of it. So that's what's going on. And this is just a different way of looking at it, but it can be a cycle that feeds back, feeds back, feeds back. So inflammation, autoantibodies, more inflammation, more autoantibodies, etc. So it can be a loop that isn't turned off. So there's the genetic, immune, and the environmental factors. So this slide I actually took from someone's presentation at the International Lupus Meeting in Toronto 2 weekends ago or 2 weeks ago. And there's more than 200 genes described in lupus, and not all patients have all genes. And so you can imagine why some people don't respond the same to treatment. Also, the immunological factors, program cell death is part of our normal tissue repair. And in lupus, put it this way, the garbage people, the garbage men, I'll say, that take the nuclear debris, the cells that have busted apart, that clear them out of your system, they're on partial strikes. So you clear more slowly. So you have more time to make these foreign proteins, because your body doesn't usually see what's in the cell because it's all enclosed. So when the cell's busted apart to be cleared, if the clearance takes longer, you're more apt to make antibodies. And that's the problem in lupus. Environmental factors could be viruses, EBV, CMV, so mono, COVID, maybe even any viruses or other infections that increase interferon, an inflammatory cytokine, an inflammatory mediator. You can flare lupus or get lupus. Ultraviolet light, smoking, alcohol, silica dust, and many, many more triggers. These are just some of the ones that are more reported. So in our Canadian database called Thousand Faces of Lupus, or CANIOS, Canadian Network for Improved Outcomes in SLE, different antibodies cluster with having kidney nephritis, lupus nephritis, kidney involvement. So as for instance, double-stranded DNA is in about half our lupus nephritis, so not everybody. Anti-Smith, a very specific antibody for lupus, is again about bit more than almost 6 out of 10 of our lupus nephritis patients, and about 3 or 4 out of 10 in people that don't have nephritis, and other antibodies. You can see all these antibodies. So it's not always easy to know who will be at risk to get their kidneys involved. Also, it is also sobering to see that even in our Canadian data, which is pretty recent over about the last 15 years, that kidney failure, meaning the kidneys aren't working right, they don't all go on to dialysis or transplant necessarily, but having kidney impairment, it's about 1 in 10 of our Native peoples, about 1 in 10 of our Asians, about 11 or 12% in blacks, about 6% in Caucasians. So we still have a ways to go, even in clinics where the patients have consented, which usually means they want to come for follow-up, usually means they want to be compliant or adherent to treatment, and usually means it's a center with an expertise in treating lupus. We still don't do as well as we would like. Not as bad as that US study I showed you, but we can do better. So the conventional problems with the treatment of glomerular nephritis or lupus nephritis is most don't get full remission, even at 1 to 2 years on treatment. It does recur over time in many people, which gives more damage to the kidneys, and using steroids can cause more problems too. So we probably use too much prednisone. So there's future thoughts. We want to treat to a target in kidney nephritis, get the protein down quickly, target the blood pressure, target the cholesterol. So we might have targets that if we get the amount of protein that the kidneys are leaking out, because the kidneys, think of it like a sieve. And, when your kids are playing, if you have kids or your friends or whatever, your friends' kids, when they're playing at the beach and they have a sifter and sand comes out, we shouldn't get sand out of our kidneys, meaning protein should not be leaking out of the kidneys. The holes have been punched too big, and so we want to repair them so the sand, or in this case, the protein, isn't leaked out. So we should have an early target to give a long-term good prediction. We should consider possibly when to rebiopsy the kidneys. We'll talk about that. When to predict relapse by biopsy, but also by biomarkers in the urine and in the blood. We want to also treat according to pathology. So, what are the signs that you might have if you have kidney lupus? It could be totally silent until you're really sick. So, you could have low blood and edema where you get a big sock line. So, pitting edema, high blood pressure, headaches when it's bad enough if you have high protein leakage. But it could be silent, or it could coincide with other organ flares. You have severe skin involvement, severe joint involvement, and your kidney function is going up and you're peeing out blood and protein, but it's microscopic. You can't see the blood. It's a small amount. It's like not like a kidney stone or maybe a bladder infection where you can see blood that you're peeing out. This is, you can't see it. We can only see it under the microscope. It's just a bit of blood. So the features are, it could be asymptomatic, it could be with other active disease. The symptoms related to active kidney disease might be mild until you're sick enough. Other symptoms could be related headache from high blood pressure, visual disturbances. If you have a severe high blood pressure, you can get swelling at the back of the eye, so edema. So it's very subtle in some people. That's why we have to check regularly. So we're going to talk about screening after, but if someone is suspected to have kidney involvement from their lupus, then they get a kidney biopsy. So the biopsy is read by light microscopy and electron microscopy. It's stained for antibodies. The quality of the biopsy, sorry about that, I just dropped this thing here. The quality of the biopsy is, how many glomeruli are present. Is it a lot of activity, some damage, and it's classified into those classes. So when should we do a kidney biopsy? So we should have a low threshold. In other words, if you have a high index of suspicion, you should send, I'm a rheumatologist, I should send them to a kidney doctor, a nephrologist, and get the biopsy done. So if in doubt, active urinary sediment, meaning protein and microscopic blood in the urine, person's kidney function could be totally normal. I might send, especially if antibodies, anti-double-stranded DNA is elevated and complements C3, C4 are both are low. When to rebiopsy? If there's a flare later, if we're thinking of withdrawing therapy and we're just not sure, if we don't know exactly what's going on over time, because I'll tell you some mimics after. So we usually, at this point in time in 2025, we need tissue to make the diagnosis, a kidney biopsy. So there are indications like more protein, active urinary sediment. So these are the ones we worry about. This is class 4. All this stuff in here is immune fluorescing, meaning antibodies laying down and wrecking that kidney filter. So there's holes that leak out the protein and leak out red blood cells. And you can see there's cells all over in this picture here. I don't know if you can see my arrow, but in the picture without the green, the other picture, and that shouldn't be there. So that's class 4. A lot of glomeruli are involved. In this case, all of them that we see. Class 5 is, you can see the immune fluorescence, the green thing, but it's a different pattern. This is membranous, and usually these people have high blood pressure, high cholesterol, low proteins in their blood because they're leaking out tons of protein. So pitting edema, the sock line that I mentioned, that you've got a mark on your leg if you press it on near your ankle. So that's class 5. Here is damage. So you can see the first pink picture, the glomeruli are gone. They scarred down. And you can see the damage on different views. And there's still some immune fluorescence because the damage was from the antibodies laying down on what we call the basement membrane, the part of the kidney. So that is a bad sign, bad prognosis. So the other thing is, I took this slide also from a presentation at the recent lupus meeting. This is a glomerulus, well, a kidney biopsy of one patient. The glomerulus is the first circle and the second circle, and they're staining for different kinds of inflammation cells, markers that are on white cells. And the two glomeruli side by side are staining different. One is a lot more of the purple or fuchsia color, and the other has some fuchsia and a lot of green. And so they're staining different cells. So even within the kidney, there's different processes side by side, and that's why it's sort of difficult to turn this whole process off quickly and to turn it off fully. It's difficult. So the guidelines say for every lupus patient, you should screen for protein in the urine. We should look at the urine for red cells as well. We should do it more frequently in early lupus, but even in established lupus. So the highest chance of getting kidney lupus is in the first few years. But if someone got really sick and flares again their lupus 10 years out, they could get new kidney lupus or flaring or recurrent kidney lupus. If you suspect lupus nephritis, do a kidney biopsy. We treat promptly with prednisone or intravenous steroid, Solumedrol, we call it, without waiting for the biopsy results. We have to explain and prognosticate how much protein is going on. So if we can't explain it, we should do a kidney biopsy. Um, Everyone with lupus nephritis, just like everyone where possible with lupus overall, should be offered hydroxychloroquine. That's Plaquenil or hydroxychloroquine, unless if they're allergic or can't take it for another reason. They should all have their protein treated effectively. That's with ACE inhibitors or ARBs. They might need excellent blood pressure control, cholesterol, etc. So that's some of the guidelines. And then we should start treatment immediately when the diagnosis is made. We're starting prednisone while we're waiting for the diagnosis or intravenous steroids. So we should start with mycophenolate mofetil, also called Cellcept, or we call it MMF, or its cousin Myfortic. Or cyclophosphamide, usually intravenously if we use cyclophosphamide. And this is what's new. And at the beginning, from the beginning, they should be offered another drug, either belimumab or a calcineurin inhibitor. Calcineurin inhibitor is voclosporin, but we don't have that really covered in Canada or reimbursed in Canada for most people. So for us, it could be tacrolimus or rarely cyclosporin, or a new kid on the block, obinutuzumab, which in your the easy way to know about obinutuzumab is it's rituximab, but stronger. We should limit the overall prednisone, the steroids, and a pulse of Solumedrol intravenous may or may not be necessary. So in our clinic, we do 1,000 milligrams of the intravenous cortisone. So Solumedrol, 1,000 milligrams daily times 3. And then we only start on 40 milligrams of pred usually and taper quickly. So we used to start on 60 milligrams of prednisone after the pulse and taper slowly. I know in Toronto, the lupus group, they often don't pulse at all with the glucocorticoids, at least the rheumatology side. So this is what I just explained. Everybody who is class 4 or 5 lupus nephritis, and even class 3 where appropriate, needs mycophenolate mofetil, Cellcept, MMF, Myfortic, or rarely cyclophosphamide with one of these other drugs and prednisone and Plaquenil and treating all the metabolic derangements, treating the to reduce proteinuria, etc. How long should we treat? About 3.5 years after you get remission, and then you might consider tapering. Now, if I have someone that's wanting to get pregnant and their kidneys lupus has been quiet for 2 years, they can't be on mycophenolate mofetil. It's for pregnancy, so I might switch them over to azathioprine, but I'm not tapering. I'm trying to continue to maintain immune suppression. I'm not tapering right away. So this was a nice study just presented at our American Rheumatology meeting in the fall, looking at what are the predictors. So immune suppression, if you've had kidney lupus, should be tapered only gradually, only after they've been in remission, a complete renal response, it's called, for 3 years or more. And if they've rapidly got well and they've stayed well for a long time on their kidney lupus and their lupus overall, you have more success with tapering. So we never used to talk about tapering. So duration of treatment for lupus nephritis, a few years of good kidney response before you think of tapering, if it's tolerated. Why do we need a biopsy? We want to give diagnosis, prognosis, but there's mimickers, someone with a type 2 diabetes or type 1 diabetes, someone with high blood pressure that also, these people also have lupus, someone with clotting in their kidneys, antiphospholipid antibody syndrome, someone with an allergic reaction or a different kind of kidney involvement that's not in the glomeruli but interstitial, someone with sudden illness, their lupus might be flaring, they're dehydrated, maybe they have pneumonia or something, they can have acute tubular necrosis, which is acute kidney failure that would not be treated this way. It's treated differently, or another diagnosis altogether. So we need a kidney biopsy for diagnosis and prognosis and to get on with the right treatment. So immune suppression, supportive care, treat all the comorbidities, lifestyle, and avoid, which we'll talk about, and avoid toxic medication or toxic habits like don't take NSAIDs, as if, for instance, if you have kidney lupus. So hydroxychloroquine should be used in everyone, and it might increase or improve the response to the CellCept, mycophenolate mofetil, or MMF, in kidney lupus. You also want an adequate vitamin D, so I put everyone with kidney lupus on vitamin D. Plus, I'm giving them prednisone, which then you don't absorb vitamin D as well. So the treatment is to normalize kidney function as fast as possible and to lower and stop the protein leakage so that we want to heal the lesions in the kidney. And we think of induction therapy at sometimes higher doses and maintenance maybe at lower doses. And the immune suppression depends, but I gave you some of the ideas. The other thing that's important, so hydroxychloroquine, treating blood pressure, treating cholesterol, giving calcium and vitamin D to maintain good bone health, but vitamin D adequate replacement will help kidney lupus improve more, help the effects of the CellCept, the mycophenolate. ACE inhibitors or angiotensin receptor blockers will reduce proteinuria and treat blood pressure, but SGLT2 inhibitors, they're the drugs that are used in type 2 diabetes. They're also used now in lupus nephritis to inhibit proteinuria. That's not the Ozempic drugs, it's the other drugs like Jardiance is one of them, etc. So these are now the standard of care, and they've been proven to reduce proteinuria even in a non-diabetic in other kinds of proteinuria in the kidneys like membranous and lupus and other nephritis. So this was a study saying, do we need these high doses of prednisone and do we need to pulse patients? And the answer is they looked at all the randomized controlled trials and you don't need to pulse patients, although you get better faster if you give that intravenous prednisone. You might not need to pulse for 3 grams in total, maybe less. And you can start at lower prednisone, about a 0.5 milligram per kilogram instead of 1 milligram per kilogram like when I trained. How do we predict outcomes? We want to see an improvement in that amount of protein and in the complements if they're low by 8 weeks. And by 6 months, we want very little to no proteinuria. But you can't heal these lesions overnight. It takes time. So we have benchmarks. There's a complete response, which looks like complete response. They have only a little bit of protein, no active urinary sediment. A partial response, they still have urinary protein, and deterioration is the amount of protein in the urine keeps increasing. So belimumab has the data. So this was a 2-year trial, and partial renal response was not even half, but almost half of belimumab patients, about a third on placebo. Complete renal response at 2 years is only 1 in 3 on belimumab. This is added to the standard of care, mycophenolate mofetil or cyclophosphamide, and it's only 20% of placebo added to the standard of care. So by the way, can we do better than this even? I hope so, but it just shows how serious a disease it is that even at 2 years, we don't have everyone, we have the minority in remission from their kidney disease, but we have almost half in remission or complete renal response. I mean, about a third on belimumab added to the standard of care. Obinutuzumab is a CD19 antibody, or sorry, a CD20, and rituximab is a CD20. This one penetrates in the tissues more broadly, deeper and more broadly versus rituximab that isn't as deep and isn't as broad. So it's better. And again, this is at 76 weeks, complete renal response, 40% versus about 20%. So again, double versus the, like it's always adding to standard of care. So that's important. And it's now, it's being, as we speak, it's being approved by Health Canada. This was the phase 3 study, and it worked in, not as well in men, but that might be like the lupus, kidney lupus is still about 80% women. So it might just be a numbers game, but it worked in whether it was lupus nephritis class 4 or class 5 for the region they were in, for the background therapy, et cetera, et cetera. And it also improved, don't worry about understanding this, but it improved the complements. They went towards normal, double-stranded DNA, more normalized. In placebo, this didn't happen. Placebo is the blue. And it B-cell depleted people fairly effectively. Obviously, placebo didn't. Voclosporin, so that's a calcineurin. So think of it as cyclosporin's close cousin. And we also have a drug, tacrolimus, that we sometimes will use. But again, renal response at 1 year, double the amount on voclosporin versus placebo, all added to standard of care. Partial renal response was higher in this study than the other studies on placebo, but again, another 20% more on voclosporin. So very important study, but because it's really expensive, we don't have good access to it. So we have mycophenolate mofetil that we might add tacrolimus to it, and that can improve kidney outcomes. This is a study that shows that. So there's also data on looking at rituximab. Some of you might have received rituximab for active lupus, including kidney lupus, but basically rituximab or rituximab plus belimumab. I think that belimumab added to standard of care, obinutuzumab added to standard of care, and tacrolimus, cyclosporin, or voclosporin added to standard of care of more data because randomized controlled data are positive in those other drugs I just mentioned. So these are the combinations that we might use. Mycophenolate with tacrolimus compared to IV cyclophosphamide as with prednisone, with hydroxychloroquine, etc. You get a better response, and half get complete remission on the combo and on IV cyclo without a combo drug. And prednisone and Plaquenil on everybody. Only a quarter get complete remission. That's why cyclophosphamide is less written about, like less accepted, but we use it if people fail MMF or if they can't take MMF for some reason, etc. So we might use it. So these are the combinations these days to think of. Trials are on anifrolumab that is approved in non-kidney lupus. Phase 3 is still underway with mycophenolate mofetil. So there's a lot of hope for people. So this is how we think after 1 year. Do you have complete remission or not? If we're not sure what's going on, maybe even a repeat kidney biopsy and changing therapy. If you have complete remission, don't consider tapering, even though it says consider tapering. Don't consider tapering till remission for about 3 years, even 3.5 years. So we're not sure, but 3.5 years of therapy and then taper instead of stopping it cold. So this is looking at tapering mycophenolate mofetil in non-kidney lupus. These patients were in remission for at least a year. It was a nice study, and tapering mycophenolate mofetil slowly but surely compared to maintaining. So tapering to withdraw over the next year was effective and without a lot of flares, but they were in remission, and this wasn't kidney lupus. In this study, the WIN lupus that was looking at tapering of mycophenolate mofetil or other immune suppression, somewhere on azathioprine in this study, they flared more. The WIN, withdrawal of immune suppression in nephritis, was not a winner. It was a loser because it didn't work and there were more flares. So you need to be in remission for more than 2 years, is my opinion. Now, some of them, not everyone went into a flare, but the flare rate was double and more severe flares if you withdrew treatment. So there's diagnostic challenges. So we want more markers like in the urine, well, your blood and in your urine. There's a cardiovascular risk. When do we reduce prednisone? How do we make trials better to help our patients? So treatments that are in research studies, anifrolumab, they're in the phase 3. It's already approved. Some of you are on this treatment. It's approved in non-kidney lupus. And it could help the kidney patients. Placebo didn't, and the kidney patients that's down here on it's the red and then the pink. It helps 75% of the people that had kidney involvement in the studies of non-kidney active lupus. Some of them would have active lupus or active kidney involvement that wasn't severe, so it helped them. What about other treatments? So the SGLT2 inhibitors are routinely used. They can decrease protein, so that's Jardiance. There's a whole bunch, but Jardiance is one you've probably heard of. They decrease heart attacks. They decrease kidney progression in lupus overall. But if you have lupus nephritis, they also decrease heart attacks even better, and they decrease the progression of kidney damage and proteinuria. This is our new standard of care. The nephrologist will automatically prescribe where appropriate, even in anyone with no diabetes, if they have proteinuria in their kidney lupus. So this is proven data, and it's been proven in a non-diabetic trial of other nephritis that wasn't lupus nephritis, but we can infer those data. So all patients with persistent protein in their urine with glomerular nephritis from their lupus should be offered these drugs, period. It is not questionable. It is true. It's proven. What about the other ones? So everybody on this call has heard of Ozempic. So the GLP-1s, that's the Ozempic kind of drugs, Wegovy. There's the oral one whose name I forget, but those things also in lupus, 96,000 lupus patients, they were better than the old-fashioned rosiglitazone, DDPI, P4 inhibitors. They were better than that, but we don't use them very much anymore because they're also better on diabetes, by the way. But so the Ozempic kind of drugs decreased heart attacks, decreased clots, decreased kidney worsening, decreased mortality. So guess what? Maybe all these drugs as well, maybe we don't have as much data now, should also be added to your kidney lupus. So you might end up on 2 diabetes drugs with no diabetes in kidney lupus. For sure, the dapagliflozin or the Jardiance drugs, and probably if it's covered, reimbursed for you, probably the Ozempic kind of drugs as well. So that is new to help our patients. Other studies, so belimumab is approved in kidney nephritis. This is a belimumab kind of different drug called telitacicept, and it looked just as good on non-kidney lupus as belimumab. They don't have the data in kidney lupus. I suspect it would be very similar to belimumab, but they don't have the data yet. CAR T therapy, everyone's heard of Dr. Schett's article that depleted certain little pocket of cells. They got primed with chemotherapy. They didn't have damage. They had active kidney nephritis that was treated, but they couldn't get them off prednisone or it wasn't fully in remission. And lots of patients went into, now we have data on remission at like 5 years. So very exciting, but CAR T is expensive. It's there's side effects, but the biggest side effect is cost. So it might not come to Canada in the forms of CAR T that you're seeing now. There's 70 lupus trials in CAR T right now going on around the world. 70. It's crazy, but exciting times. This is another one, a different kind of mechanism. We don't know much about it, but it's in kidney nephritis. So that is going into phase 3, I think. So we'll learn more. So, what do I think is important? We need early identification and treatment of lupus nephritis. We screen our patients regularly with looking at their urine, looking at protein in their urine, especially in early disease. I do it more often. We have a low threshold to get a kidney biopsy or to repeat a kidney biopsy. We're searching for biomarkers that aren't as invasive as taking a chunk of your kidney. It's just a small biopsy, but still, we're looking for that. Everyone with lupus nephritis class 4 and 5 needs what we call triple therapy, MMF, that's your Cellcept or cyclophosphamide, with prednisone, with an advanced therapy, with hydroxychloroquine, with blood pressure and cholesterol treatment. Use steroids at first, taper rapidly, limit the overall dose, make sure they have good vitamin D, check and improve adherence, because if you don't take the drugs, they don't work. And when people are sick, they take them and then later they go, oh my goodness, it might be a burden of too many pills, and they might not understand why it's so important to take the pills for a long time. You need good dialogue with your specialists, the rheumatologist, and nephrologist. Who's doing what? Who does this, who doses what, etc. Try to improve adherence. So having a good rapport with your doctors, it will improve adherence. And we don't want people to flare because they could lose kidney function and need a transplant or go on dialysis. Continue to monitor the other organs, improve mental health, encourage exercise, good diet, and there are free resources on the internet, including in Ontario. Consider if and when immune suppression can be tapered and or withdrawn. Avoid pregnancy when you're on um, captopril, ramipril, so losartan, other drugs that are in perindopril that are not safe in pregnancy. MMF, Cellcept has to be stopped where possible before pregnancy, and treat the comorbidities. Aim the blood pressure like a type 2 diabetic. Reduce the protein. Give the SGLT2, maybe a GLP-1 as well. Good fluid balance. Make sure the sodium, the salts are okay in the blood, sodium and potassium. Give the lipid target like a type 2 diabetic, in my opinion. Treat any other things, ideal body weight, aim for that. Treat the blood sugars if they're off. So lupus nephritis needs to have a rapid diagnosis. Prednisone, we want to limit it, but we still need it initially in this condition for sure. We need hydroxychloroquine. We need to treat heart attack risk. We need to treat all the proteinuria. And certainly SGLT2 is in if you have proteinuria. And GLP-1 has a protective role for heart attacks and strokes, but also probably in preventing kidney damage, even in a non-diabetic. So let's open it up for questions. And I'd like to thank everyone for thus far attending. And I'd like to tell everyone that some of our research, some I presented from our Thousand Faces of Lupus or a Canio study, but some research on our site and other sites has been kindly sponsored by Lupus Ontario. And for that, we are extremely grateful. And I think it helps give us a chance for more hope for patients. So let's open it up for questions. There's already some. Yeah, so great suggestion to start with Benlysta or rituximab, or now rituximab will probably be replaced by even more effective obinutuzumab. That's important for sure. So class 5 nephritis, can you have kids? Yes, but you want not too much proteinuria, and you need to be maintained on drugs that are safe in pregnancy. So azathioprine, if tolerated, is fine in pregnancy, whereas Cellcept, which is MMF or Myfortic or mycophenolate mofetil, isn't safe in pregnancy. Some drugs that reduce protein are not safe in pregnancy. So we know how to do all that. So do high risk OB. So do fetal maternal medicine, so does nephro. So we know how to like when to counsel and when to try to get excellent blood pressure control. We put women who get pregnant on aspirin right away. Lupus patients need aspirin 2 a day, 2 baby aspirin a day when they're pregnant. So lots of things we do. Um, I'm not sure if there's more questions. I can also, while people are thinking of questions, because we do have some time, I can tell you that my patients always say, okay, What's our target? Can I use some of these vitamins that someone else has recommended to me? Is there any drug interaction if, say, someone's on a natural product or a herb or a supplement? So we talk about that. We talk about mood because prednisone can make your mood low. Being fat cheeked and gaining weight and having stretch marks can make your mood low from all the prednisone, the cortisone. But also being really sick and some of the drugs make you feel sick can make your mood low. So we talk a lot about depression, whether it should be treated, whether it should be like treated by meds or by talk therapy, etc. So there's a lot that my patients will ask me that if they don't volunteer it, I don't always ask. Birth control is important. If you're at risk of getting pregnant while you have active kidney lupus, because active kidney lupus has a high chance of miscarrying and has a high chance of mom really flaring the kidney lupus if they're already flaring when they get pregnant. So we talk about that a lot too. So I am opening it. Okay. What doses of vitamin, calcium, magnesium? So vitamin D, who knows? 1,000 or 2,000 units a day. Sometimes I'll check a vitamin D and give a higher dose if they're low. Almost everyone in Ontario is low during winter, and we're not even always normal during summertime. And you are going to be sunscreening usually and staying out of the sun if you have sun sensitization. Well, if it causes your lupus to flare, you're going to avoid the sun. So you even might have lower vitamin D than, say, if you had a friend who doesn't avoid the sun or a sibling. Calcium, it's usually best to get it from the diet, which is 2 full servings of calcium rich products a day, which could be yogurt and a glass of milk, cheese and cottage cheese. Broccoli, believe it or not, has lots of calcium, which I learned. Salmon, but not everyone's going to be eating salmon every day. It'd be too expensive. Magnesium, we don't need. Some people take magnesium. Magnesium, there's some thoughts it helps absorb calcium better. It's not really proven to be the case. Like it's not unproven, it's just not proven. So I don't recommend calcium, but sometimes, sorry, I recommend calcium mostly from the diet. I don't routinely recommend magnesium, but magnesium, if you're really constipated on calcium, can actually make your bowel movements a little bit better, easier to like softer, not as constipated, but you don't have to take magnesium. Some people say it helps their leg cramps. Some people say, well, I'm on a lot of water pills, diuretics. If you have the protein leakage high in your urine, proteinuria high, and then people with that might take magnesium because it might help. You might pee out more magnesium if you're on a lot of water pills. Okay, so there's another one, years of proteinuria, severe pitting edema. So that's the sock line is major. Ascites, so a lot of fluid even in the belly. 12 pound water weight gain over 24 hours, but kidney function is okay. It could certainly be lupus nephritis because of the proteinuria, so it probably is. And it should have been diagnosed by somebody. So when there's a lot of protein being peed out, I would say for someone like that, they need a kidney biopsy. If they already had one, it could be re-reviewed. They might need another one because it's years of this. But you can also in lupus and in some other conditions lose protein in your bowel. So not actually um, from your kidneys, where you would have little or no protein in the kidneys, but diarrhea and loose bowels, and you can lose protein, malabsorption kind of thing. And that can be from lupus. It's pretty uncommon, but it is well described. But if there's proteinuria and ascites, then this needs treatment. That's my opinion. Any other vitamins or supplements I would recommend? Some people swear by some of their supplements. In general, I mean, you're sick when you have kidney nephritis, especially at the beginning. Sick, you're on a lot of different medicines. So, optimizing vitamin D, trying to get calcium in your diet, if not taking calcium pills. Other vitamins are very it's hit or miss. Not everyone would be deficient on B12, as a for instance. So sometimes people feel better taking a multivitamin. They don't, doesn't make them feel better. They feel better because they're doing something. But no routine supplements right now that I can say, oh, if you have kidney nephritis, you must take this or don't take that. There's not a lot there to tell you. When you have a lot of protein you're leaking out, you can pee out more factors in the liver that um, keep your blood appropriately thin. So you're at higher risk of clotting. So sometimes this isn't a supplement, but sometimes people, if they've had a clot because of peeing out so much protein and imbalance of peeing out more of the anticoagulant and less of the procoagulant, then they need a blood thinner, but that's a different thing. If you have a blood thinner, we don't want you taking vitamin K. Totally different question, but it just I thought of it. So wanting to get off prednisone, what are the alternatives? So we want people to get off prednisone where possible when their disease activity is low or hopefully remission. So the alternatives are making sure there's enough appropriate use of immune suppression so that the lupus is quiet. And getting off prednisone is extremely problematic for people, especially the longer they've been on it. So, say if someone's on 7 milligrams of prednisone and they've been on under 10 milligrams of prednisone for 5 years, I can't say, oh, go 7, 6, 5, 4, 3, 2, 1, and in 4 weeks or 7 weeks get off. I might have to lower 1 milligram of prednisone every month or two to if you've been on a long time. If someone's on high dose prednisone, it's not appropriate in the long term. We need to get them down, which means we need to change their immune suppression and we need to educate the person why prednisone is so bad, even though every time they go down, they feel terrible. So we need to go get the high doses down quickly to then a reasonable dose, which is a variable dose. It's not always the same in every doctor's mind or in every patient's mind, and then go very slowly. So that's an excellent question. I think another one's coming up. Thanks for keeping these questions going. So, yeah, so DAPA, so someone was asking about Jardiance. So basically, Jardiance is the DAPA DAPA Go Flosin or something. I don't even know if I'm saying it right, but basically that is really important for if you have protein in your, like you're leaking out protein after 6 months of treatment with good treatment for kidney nephritis. If you're still leaking a lot of protein, that would be used in everyone. If you have a trace of protein or 1+, probably not. I think they were asking about an interaction of another drug. I'm not sure what Kerendia is, so I'm not sure about that one. So I'll look at another question and get back to you on that. 10,000 units of vitamin D for a year is still low vitamin D. Is it related to lupus nephritis? Well, it could actually be related to prednisone if you're still on it. That can decrease absorption and also steal bone density. So it reduces absorption in the GI, in your gut. But some lupus patients have antibodies against vitamin D, so they're always low. So what I do sometimes, I'm not saying this is the case for everyone, but if vitamin D is really low, I sometimes give, this sounds really high, 50,000 units of vitamin D once a week for about 6 months and then recheck. Also, you can get, I think, intravenous vitamin D because maybe you're not absorbing it right. So 10,000 units of vitamin D weekly, say for a year and still low on vitamin D. Ask your doctor, say, should I go to an endocrinologist and maybe get a different idea on how to treat this, how to get the vitamin D up. Okay, wanting to get pregnant, if there's kidney nephritis or active lupus, how long should you wait? So we say, please, please, please. I know it's different if someone's 41 years old and they're trying to get pregnant. They're not, I can't make them wait 3.5 years because they might not be able to get pregnant at all as the clock ticks. But basically, if someone's younger, I say, please, 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 let's get kidney lupus, not good, great, in remission for 3.5 years. Then let's taper the mycophenolate a bit. Then let's switch mycophenolate when it's a lower dose over to Imuran, that's azathioprine, which is safe. And if lupus markers are still good, I say go for it, try to get pregnant. So we want this to be planned because surprises, meaning not planning and getting pregnant, is harder for mom and less apt to have a good outcome on baby, unless if the mom's on the right drugs and in low disease state or remission. So that is an excellent question. Really, really good. And that's for the class 5 lupus nephritis. You might get more protein during pregnancy if you want to get pregnant, because when you're pregnant, you double the filtration in your kidney. You get more volume. That's why some moms have a little bit of sock line or edema, like you can see the sock mark on your leg, because you have more volume. Okay, there's lots of great questions. So I'm looking here, waiting, that one we answered. Okay, how long in remission before trying to get pregnant? Longer is better, but you don't need, if you don't have kidney lupus, I would say, it's my opinion, I would say remission for about a year and then trying to get pregnant. Kidney lupus, we want remission for longer because kidney lupus likes to wake up in pregnancy, and that's harmful for kid and for mom in general. Um, okay, so someone's moving, so they'll have to get a new specialist. They've been on prednisone for 4 years. Should they be worried? Can clinics help? They've been on methotrexate, so probably skin or joint involvement. So one thing I would think of is looking at with the new specialist after you move. No specialist yet. Ask if your old specialist can do a phone opinion, a phone consult with you until you get a new specialist, and ask your old specialist, hey, do they know anyone in the area that they could refer you to? And then can you slowly taper prednisone if you're doing well? So we have to taper most people slowly if you've been on prednisone for 4 years. If you've been on prednisone for 4 or 5 months, we can usually taper more quickly. So that's an excellent question. What's the best high blood pressure treatment for lupus nephritis? Any that control it. So usually we use an ACE inhibitor or an ARB. So that's ramipril kind of drugs, uh, losartan kind of drugs. There's like about 10 drugs in those two families. Then often adding amlodipine, but that can sometimes make your ankles puffy. And if you're already puffy, you don't love it, but it's a good blood pressure med. Maybe adding an alpha beta blocker like labetalol, certainly adding a water pill, a diuretic, if there's a lot of protein being leaked out with a lot of swelling, edema, peripheral edema. So any blood pressure med, but they don't have to be fancy and expensive. But we do like trying to use the ACE inhibitors or the ARBs if there's proteinuria. That's two classes of drugs that are close cousins. Um, what about our edibles? Okay, so by edibles, I'm assuming we mean like sort of these gummies or stuff that are THC or CBD, one, the other, or both. Um, I basically they're legal. We haven't studied them very well for helping people with um, pain, but some of my patients, not all, some say it helps their pain. Others say no, it just makes them feel weird and doesn't help with their pain. So I'm not against anyone trying, but they should consult their doctor if their lupus has been active, just to make sure it's safe. But in general, it can be safe, and some people it's effective. I think a lot of people, if they get a side effect, but it's helping them, they lower the dose. Again, the most expensive side effect of edibles is the cost because they're not covered on drug plans. Um, and I think, too high a dose might make you feel tired or impaired, which you're not trying to do. You're trying to help with pain. There's other meds that can help with pain. Sometimes no one drug will help everyone, but sometimes physical modalities, heat, exercise, distraction, mindfulness, sometimes medicines, high dose acetaminophen, that's Tylenol, avoiding NSAIDs though, like Motrin, naproxen, Celebrex. If you have kidney lupus, if you don't have kidney lupus, you can try an NSAID. You might try Cymbalta, that's duloxetine, that is approved for depression, but also approved in pain and also approved weirdly in arthritis pain as well. Weird because I wouldn't have thought it would help that kind of pain, but it can. Um, there's pregabalin, which is Lyrica or gabapentin, that's Neurontin. That sometimes helps burning pain, widespread pain, fibromyalgia type pain, but there is no one pain med that helps everyone. So you want to discuss with your doctors or your nurse practitioner, your healthcare provider, and say, what is safe with my lupus and with my meds I'm on that can give me pain relief because I need pain relief. If you have widespread pain, because not all, but some of our people living with lupus are struggling also with fibromyalgia, having had a pain condition like lupus affecting joints or skin or whatever increases the chance of having chronic widespread pain. So, fibromyalgia, our target is not to get people pain free, it's to make it tolerable and to give their life back, to expand the horizons of being able to do more things. So these are really, really excellent questions. Um, what about correlation with hypermobility? People who are lax in their joints, like say they can put their thumb over to their wrist, or they overextend their shoulders or their knees, so hyperextension, including Ehlers-Danlos, but some people are hypermobile without that that's a genetic condition. Without that condition, are more apt to have injuries. So if I keep traumatizing my thumb because it goes out of joint, I'm more apt to get arthritis there, but even if I don't have arthritis, I'm apt to get pain. So hypermobility can increase pain, but hypermobility is not related to lupus, but some people have more than one issue going on, right? Hypermobility is a common finding in the general population. Probably a few percent of our of people of women are hypermobile, I would suspect. Um, we're at the hour. I'm happy to take one or two more questions, and I realize some people might have to hang up, and that's fine. But it looks like I think you guys did a great job. I think we got to all your questions. Thank you. Oh, one new message. Oh, just a thank you. Yeah, you're welcome.
Thank you so much, Dr. Pope, for your time today and a wonderful presentation. It's so nice to hear about all the advancements in research and the new ways to treat lupus nephritis. I know everybody in the community is excited to hear about that. Thank you so, so much. For everyone else, we will be posting the recording of the webinar very, very soon. Keep a lookout on our YouTube channel and have a great week ahead.
Thanks, everybody. Bye bye.
Thank you.